Thank you so much. I have 10 minutes. I would like to focus on three, innovations that could be very important in the future. First one is how we can assess objectively the speech strategies that the companies are providing to us, especially with regards to listening effort. Then, how can you minimize the trauma to preserve the structure? And I will say a few words about what are we now about drug-eluting electrodes. And then how could we insert the electrodes more precisely and perhaps with less trauma to the cochlea in order, again, to preserve the structures. So first, pupillometry. You know that our pupil size is changing when we have a listening effort or any effort, and it is well known now. And what we try to check in our department is to control the listening effort by pupillometry. So we place the patient in noise, and you see here you have the sentence and the noise is increasing. So at the beginning it's very easy, silence or not a lot of noise, and at the end with SNR like 0 or -3, there's a lot of noise and it's difficult for cochlear implantees. It is a setup in the lab. It's in our clinic, so it's quite easy. You just wear goggles, and then it's what it looked like. So you see, you have a sentence. Your effort is increasing because you try to recognize the word, and then as soon as you have repeated the word, then you see the effort is decreasing, and so on. So what is a normal profile for a patient? If you hear normally, you have at least no effort, or really at the end when there is a lot of difficulty because a lot of noise. But even if our cochlear implantees perform very well in noise, if we compare to severe deafness with conventional hearing aids, they have to pay a lot to the listening effort. And even at the beginning, as you notice here, you have a lot of cognitive load, even when the SNRs are very favorable with little noise. So it's very interesting that we have to take care of that, and that our patient may become a bit tired at the end of the day if they're within some noisy environments. But we have the objective way to prove that and to compare if you have different strategies of speech coding, for example, of microphone directivity. We can just analyze what is really the outcomes. Next, a few words about what about drug-eluting electrodes. And what we know with regards to what we've done in the lab, we know that if we place one electrode on one side in an animal or gerbile, a normal electrode, and the other side there is a dexamethasone eluting electrode, what happens? You see that on the side without dexamethasone, you have the impedance are increasing. But if you compare to the side with dexamethasone, there's really a very stabilization with low impedance. So something is changing in the electrode tissue interface. And the question is, what is changing? And what we've proved now, we publish that many labs around the world publish exactly the same. In fact, when you insert an electrode in a cochlea, it could be in human, animal, you have a kind of fibrous tissue surrounding the electrode array. And if you compare one side, and if you put this cochlea in a confocal microscope so you can study volume, it's much more efficient, then you can see clearly that here you have a side with normal electrodes, you have a large volume of fibrosis, and here you have the side of dex-eluting electrodes, and you have very diminution of the fibrosis, explaining why the patients because now we have two companies, Medel and Cochlear, starting to clinical trials, and both are demonstrating very low impedance, or at least lower impedances if we compare for the normal population. So I guess in the future, that will help really helping the surgeon, the team, to provide real conservation, structure preservation. And you see, if you look at the first human trials with DEX releasing electrode, first is safe. There is no major adverse effects. Of course, these are preliminary results, so we need to take care. And it could be even with Medel or Cochlear, impedance are decreased by a factor 3 to 5, which is quite interesting. Of course, we need to confirm that with a longer follow-up. What could be the advantages if these electrodes are able to decrease the volume of fibrosis around the electrode? It may help in preserving the cochlear structures. And it's good because if you leave the cochlear empty on fibrosis, you may use it for future inner ear gene therapy or reimplantation. Of course, if there is a kid, perhaps he will be reimplanted in all his life 2 or 3 times. And if your cochlear is completely empty of fibrosis, it's much better, much easier for the surgeons. It may help in preserving residual hearing. And then, of course, if you have lower electrical consumption, you have a longer battery life, which may be good if we think one day we have some kind of fully implantable devices. So we are on the way to preserve the cochlear structures better and better. And how could we do better during surgery? Certainly by inserting with less trauma the electrode. And this has to do with robotic insertion. My experience in my center is with Robotol, but you have other teams with other robots. And this robot is really adapted to the otologic surgery. There should have been a video, but the video is starting. Oh, it's good. I will save time. And you see, what is very strange, you didn't see 3 minutes after, you didn't see, you don't notice any movement. It's so slow that you think that nothing is happening. And you see, 3 minutes after, it's still like it's not moving, but it's moving anyway. And what surprised me is the lot of perilymph egressing from the cochlea. And you see 2 minutes after, so 5 minutes insertion, we are nearly at the end of the insertion. And it's really not possible to insert an electrode in 5 minutes. So you see, it's very, very controlled and slow movement. Of course, it answers the question about controlling the speed of insertion, but it does not control the force of insertion, and perhaps more importantly, it does not control the axis of insertion. So we need to progress on that. And the last innovation I would like to share with you is about what we've done with associating navigation and virtual reality, augmented reality. So we do that with a navigation system, and we inject the image in our microscope. Of course, you need to plan. It's easy. You have endpoint. It's the center of the scala tympani, and you have an entry point is vary from the size of the posterior tympanotomy, and then you may angle the axis of insertion, and you can project during the surgery. You inject the image of what is the ideal axis of insertion you have planned before surgery. So it may help really going for even better outcomes if we add that with robotic insertion. So where are we now with robotic insertion? Yes, we think it's feasible in adults and children. We control the speed, of course. We still have to position manually the axis of insertion. For the moment, we have no real interaction with the monitoring tool. and like fluoroscopy or electrocoagulography, for example. And of course, we need to evaluate the cost-benefit ratio in a large number of patients. It's what we have started in France. We have a multi-center randomized study to demonstrate any benefit. Thank you for attention.
Thank you, Professor Vincent. Is there any question to Professor Vincent? So it was clear, and the unique experience that you have this chance to use Robotol. So we have, thank you. So I call Professor Nicolas Corentin for the next presentation. Telemedicine in cochlear implantation. So you
Yes,
can
hello.
go.
Thank you for the invitation. I will present some data on an experience we have done with the telemedicine and an experience we are doing. In fact, we know that in the cochlear implant center, there is a problem that the burden of the patient is increasing. The number of the patient is increasing. And most of the times, sometimes they come back for appointments, but most of the time they don't come back for appointments. Of course, telemedicine can represent something that can help clinics, but can also and mainly help patients. The problem of follow-up is a problem that has been already described in the literature. In fact, some patients, they do not come back because they are happy, they are satisfied with their results. Some patients may not perceive that something is going wrong. Some patients may perceive that something is going wrong, but they cannot afford to go back to the clinic, or they have economic reason or personal problems that do not lead them to go back to the clinics. Some years ago, we have done a study that we have published on Acta Otolaryngologic, and we have evaluated a number of patients that were not coming back for follow-up in our clinic. And you see there are patients, there were 13 patients that were not coming back for follow-up from 12 months up to almost 10 years. So what happened with those maps? The maps, of course, had to be changed. And in fact, even if those patients thought that everything was okay, we had to change the map up to 6, 7, or even 9 levels with an improve of the speech perception. So even if patients are satisfied, not always this corresponds to the hearing function. So the problem of follow-up is, of course, an important problem. In order to solve this problem, all companies now, they have proposed some what is called telemedicine. So they have proposed some option to check the implant remotely. And in the last years, also there have been proposed some solution to map the implant remotely. But there are not many studies that have evaluated the efficacy of these methods, and therefore we don't know if this remote assistance or remote check or whatever we want to call them are efficient and are effective both for patients and for clinics. So, for example, we are performing in Europe a study that is called INSPIRE, and I will just briefly present this study that wants to evaluate the real effectiveness of the cochlear remote check and remote assist features. Remote check is an hearing health tool that allows monitoring CI patients from remotely, and in fact with this function we can evaluate the implant site. We can ask patients, we can present AFib, SSQ and AFib questionnaire. We can perform a remote audiogram, a speech in noise test, check the implant impedance, and also, of course, evaluate the data logging. But cochlear remote assist is a function that helps us also in adjust the map and adjust and enable processor setting. So the INSPIRE is a post-marketing prospective multi-center open-label comparative interventional study that wants to evaluate the real effectiveness of remote care and remote assist and remote care by randomizing patients in two arms, in clinic care and remote care, and of course evaluate not only the performance of those patients, but also the economic, the eventual economic effect of this way of mapping the patients. There are 10 sites in Europe, and we want to capture the time and cost associated with both models. This is there are supposed to be involved and randomized 148 patients with 10 study sites that are in Italy, UK, Netherlands, and Belgium. And these are the pre-I of the different sites. We have just submitted a paper on the protocol, and we have just started with the recruiting of the patient that started in April of this year. And this is the schedule of events. As you can see, after screening and baseline, after screening of the patients will be randomized one-to-one in clinic group and remote care group. In clinic group, patients will perform mapping and whatever is needed in clinic, and then will be follow-up. While remote care, patients will be remotely checked, remotely assisted, remotely mapped, and then evaluated over time. At the end, of course, we will evaluate not only the hearing function, so the audiogram, speech in noise, speech in quiet, as well as the questionnaires, but also, and what is the main objective, I think, of this study, the time and cost survey, and also the evaluation of the cost saving. This, I think, will help patients, will help clinics, will help companies, because if you demonstrate that this approach is effective and is also cost effective, of course, this can be applied everywhere. Otherwise, we only have companies that tell us about we can do that, we can do this, but at the end, we don't know if this approach is really effective and really functioning. Thank you for your attention.
Thank you again, Professor Caranta. Is there any question for Professor Caranta? It was clear. So thank you again. So I call Professor Badruddin for the next session, the webinar of, I think the next is, yes, the last one. Is here, okay. Professor Sherif El-Gimdi, recent advances in tympanic membrane surgery.
So, Mr. Chairman and dear colleagues, we'll take you a little bit away from the cochlear implants and talk about something maybe more common. Innovations in myelingoplasty. What does the future hold for us in the area of a perforated tympanic membrane, which is something a little bit common, and it can be a traumatic or a pathological. And it, as we know, it results in some morbidity to the patient with his hearing deterioration, with a recurring otitis media. And of course, up till now, the gold standard has always been surgical closure with the different types of autologous tissues, which are available more or less in the vicinity of the surgical field. But we don't really have a good consensus on the optimal material to be used. So it remains a challenge. We have a lot of grafting materials available. In most of the literature, we have around 80% success rate. Sometimes we have an incomplete implantation. We can have rejection of the graft with the need of rehospitalization, reoperation, general anesthesia, and all that. So what if we could program the tympanic membrane to repair itself after a perforation? And this could be something, of course, very interesting. So that's where the regenerative therapies in the form of the tissue engineering would come into play. And tissue engineering, by definition, is an interdisciplinary field which applies the principles of engineering and the life sciences towards the development of biological substitutes which will restore and maintain and improve tissue fabrication. So in cases of a tympanic membrane, we will talk about something that will be an offshoot of the conventional laryngoplasty. We will replace the autologous material with biomaterial-based artificial patches, which should eventually, and at least in the lab or in the few studies that have been made, should give a higher and faster rate of closure. So why would we choose tissue engineering? First of all, because it has the advantage of generating a trilaminar membrane. And this trilaminar membrane, which with the 3 layers of the tympanic membrane, will reproduce the structure, the mechanical properties, and the function of the original tympanic membrane. And most of all, it can be office-based. We don't need to take the patient through a general anesthesia and hospitalization. So tissue engineering will involve 3 main factors, which are the bioactive materials, which when they are placed in a suitable microenvironment, they will lead to proliferation, migration, and differentiation of living cells, which are the second ingredient, I would say, over a supporting scaffold, which is the third ingredient or factor. And these factors can be used all alone, each one alone, or they can be used in combination. So to talk first about the scaffold would be a 3D arrangement of a porous biomaterial. It will act as a template for cell adhesion, for growth, subsequent tissue formation. And the implants, which is the scaffold, will be gradually replaced by the new extracellular matrix deposited by the cells. Important properties of any scaffold that we should use or manufacture should be biocompatibility, biodegradability, mechanical properties, porosity, and of course, it should be easy to manufacture. It should be made of a bioresorbable material. We could have natural materials, naturally derived polymers, or synthetic materials. The natural material is like the alloderm, which are decellularized tissues. They preserve the functional proteins, they preserve structural features of the native tissues, they mimic the inherent extracellular matrix microenvironment, but they also have some problems in the form of batch variability, biosafety concerns, ethical concerns, of course, because we're using dead tissues in the case of the cadaveric skin, like the alloderm, residual antigenicity, which could be a factor, and immunological reaction and rejection. The second one would be the naturally derived polymers like collagen, and it has the advantage of being similar to the tympanic membrane fiber, and it maintains its cell structure and function, but also the hyaluronic acid also, or silk fibroin. And the third one will be the synthetic material, which is a collagen immobilized PDMS. Its advantage is that it has a low toxicity, physiological inertia, and good mechanical properties. So on the market, or very closely to be on the market, we would have the EpiDisc is already there. We could have also the clear drum, the TimCure, and the phonograft. These are 4 scaffolds. The first one is the EpiDisc, which are 2 layers of a patch of hyaluronic acid sandwiching a dry temporalis fascia graft. The second one is the clear drum. It looks like a contact lens. It supports the growth of the tympanic membrane cells, and it promotes tissue regeneration. And it is made of silk, which is an FDA-approved natural protein with a good biocompatibility, tunable degradation, mechanical strength, good material supply, and easily scalable production. The third one is very interesting. It's the TimCure. The third one comprises a handle which will insert the scaffold. So we start by doing a local anesthesia to the tympanic membrane. We insert our handle throughout the perforation, and with this handle, which incorporates sort of a knife, we would trim the edges of the perforation. We retract a little bit our handle, leaving one part of the scaffold inside and the other one comes outside. And then we press them together with the release of the hand, and we get 2 layers sandwiching the rest of the tympanic membrane. The last one, or the fourth one, is the phonograft, which was inspired by Harvard University, and it's 3D printed from biodegradable elastomers. And it has an inserter. It goes past the perforation of the tympanic membrane, and this is how it looks when it is kept in place. The second factor I'll talk about is the biomolecules, or the growth factors. And these are bioactive. This is a bioactive stimulus, and this growth factor will instruct the cells during physiological development and would induce 3 prime activities of the cells, which is mitosis, proliferation, and morphogenesis. The repair of the tympanic membrane will be stimulated by these growth factors. The 2 most important are the epithelial growth factor and the basic fibroblastic growth factor. Sometimes we use also the platelet-rich plasma, the PRP, and the way it is done is that we do a local anesthesia still in the office. We trim the edges of the perforation. We prepare the gelatin sponge with the basic fibroblastic growth factor, which will be put inside the perforation, and it will be covered by a fibrin glue. And after 3 weeks, we remove the crusting and we get a healed tympanic membrane. So why do we do that? This is a tympanic membrane that has healed spontaneously. We can see that, first of all, it's very transparent. No nutrient vessels can be seen. The fibrous layer has stopped growing, and we can see it as a white, I don't know if we can see here. See, this is the fibrous layer, which didn't grow, so we don't have a 3rd layer. But this is how it looks if we insert a gel foam with a bioactive material. The tympanic membrane regenerates with the 3rd layer, and we can see numerous capillaries, and the middle layer has regenerated. So there has been a lot of studies about these growth factors, and most of the studies state that when we apply growth factor immediately or on a gel foam, it gives between 100 and 97% closure rate, compared to 55% when we just observe the perforation to close spontaneously. We have different studies that confirm the same results. This one is a systematic review and meta-analysis, so it really has a very good level of evidence. The third factor would be the incorporation of cells, like the stem cells. However, maybe we don't use it very much because the tympanic membrane has a very good natural repair capacity, and it can be applied by injection or integrated on a supporting scaffold. So what are the limitations of all these innovations? First of all, a little bit of high cost. Secondly, we don't have a really large-scale clinical data. We don't know how much the reperforation is, how the post-operative infection, the hearing improvement, or any unforeseen complications. And of course, we have still not studied effectively the immune response. So what's the future holding? Maybe scaffolds containing growth factors or stem cells together, better control of cell proliferation, differentiation, accurately simulate the physical and chemical properties of the tympanic membrane, and achieve the best healing of the tympanic membrane. I would like also to state that I have no affiliation with any of the mentioned companies, and I hope that in the near future we could see these innovations on the market at a very good cost and a very good price. Thank you.